just racking on more and more medications because more and more problems and, trying to find solutions with a drug. And, we end up chasing our tail or at worst, shooting ourselves in the foot.
Welcome back to Bendy Bodies. I'm joined today again by my friend, colleague, and recurring co-host, Dr. Dacre Knight, Medical Director of the UVA Health EDS and Hypermobility Disorder Center. Through our ongoing partnership with UVA Health, we're bringing you practical, evidence-informed strategies to help people with hypermobility and connective tissue disorders live better. Today, we're wrapping up our MENS-PMMS series by covering the final 4 components and sharing some of our favorite treatment pearls and clinical insights for each one of these last 4 letters. These are the approaches we find most successful and recommend again and again because they make such a meaningful difference in real life. This podcast is for educational purposes only and is not a substitute for personalized medical advice. Stay to the end for our hypermobility hacks. Here we go. Well, I am so excited to be back with Dr. Knight, and today we're going to be discussing the last 4 parts of my treatment algorithm, MENS-PMMS, and we're going to start with P for psychosocial. So I know, Dr. Knight, that it can be very challenging to approach this part of the algorithm because of the fact that a lot of people think, oh, you must be saying that it's in my head or, making some assumptions when we start talking about the psychosocial aspects of pain and other symptoms. How do you approach this with your patients?
Well, it's a lot. And thank you, Dr. Bluestein, for the question. And so glad to be back again with you. There are, so many factors and modalities and, of course, different approaches that we can take. But I would say that what has been, in my experience, really the most impactful is that it's not really one major breakthrough or just one specific miracle. It's really just kind of stacking all of these things together. So a continuous run of small wins across all of those domains that you mentioned. So if I had to rank them, I'd say that the psychosocial factors, when ordered correctly and when done appropriately, and the nervous system regulation are often the foundation, the most important foundation. And then the modalities and things like that we build on from there. So it's a combination of all of it.
And I had a physical therapist once explain this to me when I was, not doing well. And she said that we had to really work on, nervous system safety and a number of these other things. And she said, well, it's physiologic, though. It's not psychiatric. And I say that to people a lot because I think people don't often realize how the mind and body are connected in physiologic ways. And I think if we educate people about that, it's really, really helpful. I don't know why we feel like if it's psychiatric, like that it must be our fault and we must have more control over it because we don't have a lot of control over a lot of the psychiatric things too. But I think that explaining that mind-body connection can really make a big difference. What do you think about that?
Yeah, I think that's really it. Is the key is how it's explained and how you address it and how you're counseling patients and you're not kind of being abruptly dismissive, but you are seeking ways to make these connections because certainly they are physically and mentally and all the rest and that we're all psychologically attuned to whatever disorder and condition that we're suffering from. So there's no doubt that there are pieces of it that kind of draw in all of those mechanisms. But how you present it and how we discuss it with patients is a critical nature.
And I don't know about you, but I have had some really remarkable cases of just incredible transformations through programs that address the nervous system safety, whether it be, something like DNRS, Primal Trust, the Gupta program. Like there's a lot of different options out there now. Have you seen that as well? I mean, we know that mast cells do respond to psychological stress. So it makes sense that, stress can impact our symptoms so greatly, which is why gaslighting is so bad, right? That can just make the stress so much worse. People come to us for help, and if they're not believed and not validated, then it can just exacerbate their symptoms. But have you seen it work the other way where they've done some of these modalities and it's really helped their symptoms quite significantly?
Absolutely, and I think you addressed it correctly that these things can be compounding problem, but if they are done correctly, they can be a compounding benefit. And so I just had a patient just yesterday just describing the stress that she was experiencing, how it was disrupting her sleep, and she was was getting 2 to 3 hours of sleep per night for a period of days. And all of those things are just adding into symptoms of fatigue and deconditioning, and then more muscle pain and all of the joint issues that came with it. And when it came around to, just again, small win that she had adjusted some of the things that were causing her to have a lot of stress in her life. And she was able to, get more sleep. And, just all of it is just compounding thereafter. So and it may not even be just sleep that is someone is having issues with. It may be work related, family related stress, or whatever. But all of those things it's why we take it importance at all the kind of the psychosocial aspects, as I mentioned from the beginning.
Yeah, whether it's those other things that I just mentioned, CBT, DBT, which is dialectical behavioral therapy. I mean, there's so many there's another one called EAET. Have you heard about this? I know that there's some studies looking at that in fibromyalgia. In fact, I think it might have even been Mayo Clinic that was researching that and finding that a lot of people who have these conditions, or have, I should say, a lot of people who have either chronic pain, persistent pain, or other conditions, a lot of us, I'm going to put myself in this same category, we have difficulty expressing our needs. And so then sometimes our body starts speaking for us. We start getting worse and worse symptoms when part of it is we need to express what it is that we need from our family members. And so I think that's another important part of it. It's not just the safety of your nervous system, but it's also working with your support team and being able to express yourself, in a effective way. What are you feeling? What do you need from other people? And how can you get to a better place emotionally?
Yeah, and that's something that I know a lot of patients experience is finding the right people to guide them there, and whatever therapy it may be. The EAET is interesting. The acronym is Emotional Awareness and Expression Therapy, and it's
I'm
been
glad you could
highly
remember it.
yeah, it's been highly effective for a lot of those chronic pain things you mentioned. That were described as the neuroplastic or nosoplastic pain conditions, right? The fibromyalgia, and we see there's a lot in patients with EDS and HSD. But you're right, they've done some of those studies at Mayo Clinic, but even finding those, because it does require in-person care, those specialists are not everywhere and they're not in every city or community. So, and another one would be like EMDR, or trauma-informed therapy, for those patients who have a history of trauma that is kind of exacerbating some of their symptoms too. So lots of different modalities, and that's just part of the discussion working with your healthcare professional of understanding which of those types of therapies and modalities may be most suitable to you or are accessible in your area.
And speaking of in person, are you familiar with Dr. Beth Darnall out of Stanford and her program, Empowered Relief? Have you experienced anybody trying that? Do you know anybody who's certified to teach those classes?
I'm very glad you asked, because we're standing up an Empowered Relief program at the University of Virginia as we speak.
Yay!
So
That's
it,
so
I will.
exciting.
It is. So, Beth has done some fantastic work at Stanford in making this available to anyone who, like you said, is able to get the training and become a certified provider for it. And anyone in allied health can do it if they take the time to go through it. And the data has been very robust for good response from that. So we're excited to get it enrolled for our patients here, to be available to them, that they can do it virtually. And so I will definitely have more feedback for you once it's up and running here in just a matter of weeks.
Well, that's really exciting. I got to meet her in person for the first time last month. Very recently. Yes, it was last month at the American Academy of Orofacial Pain Conference, where she and I were both speaking. And I think she's really doing great work. And we will also link in the show notes the podcast episode I did with her that was quite some time ago now. But I had a great conversation with her.
Yeah, yeah. Likewise, I had met her at a Canadian Pain Society meeting a year two ago now. It's been a little while, but she was telling me about this Empowered Relief program then. So we're excited to get it involved for our patients as soon as we could.
Yeah, I think that's exciting. I'm so glad that you're doing that at UVA. And are there other psychosocial interventions that you feel like consistently improve outcomes that we haven't already mentioned?
Well, there are. So I would say, and it really, as we say in most healthcare and medical treatments, that it really depends on the situation. The conditions can be quite severe. I would say one of the most underappreciated is loss of trust. So many patients who have been coming into our center that have seen firsthand, and obviously we know this, but they've have spent years of being dismissed, misdiagnosed, and told nothing is wrong. And so that changes how they interact with healthcare overall and how they interpret their symptoms. So as far as, what we can do for the kind of the psychosocial aspects to it, um, we first have to, get it right that, symptoms are not imagined. That means that brain, body, emotions, relationships, all these things we're talking about, life experiences, they're all connected. So, physical illness, as we know of EDS and HSD, can place the nervous system in feels like this consistent state of threat, and that threat response amplifies the symptoms. So we really just start from the bare minimum. Validation. We know validation is certainly very therapeutic, and that's really the first meaningful intervention. And then thereafter, we just kind of have to peel away the layers of the years of misdiagnosis and misunderstanding, and then, reapplying the education and redirection of understanding of these conditions. And then, if there is more psychological support that's needed, we would get them partnered up with one of our clinical psychologists, one to one. If it's something that still needs to be addressed, but we can do it in a similar fashion over multiple number of patients, then we could potentially do that in a group setting. That is also been effective. It's a way of kind of, broadcasting the skills and tools and techniques of a clinical psychologist to more than one person, so it's more feasible and accessible to those patients. But there's certainly some cases that may require one-to-one evaluation and treatment.
I love what you said about validation because that's free, right? If they've already paid for the appointment, the validation part is something that we as clinicians can do. It doesn't cost anything extra. And so just saying, I believe you and I hear you is, yeah, I think that might be our most underrated psychosocial treatment pearl.
Yeah, it's step number one, and it's really it is therapeutic, and it's something that patients need to hear and have not heard, and once they hear it and understand that validation is there, then they can have much more meaningful interventions ahead.
Yeah, it can lower the anxiety and like you said, the nervous system safety can improve, and then you can start to do some of the other work. I think it can be really hard to get, a pill, which we're gonna go into medications and supplements and things like that, a little bit later. But yeah, it can be hard to get those things to work if your nervous system is just like on overdrive and you're in a constant sympathetic state.
Totally. Yep. Yeah. So kind of really just have to reset and start anew, and that's where the validation begins.
Okay, well, let's move on to the next letter, which is M for modalities. So it's very intentional that of the three M's, movement was first, which we talked about in a previous episode, which we will also link that episode. Oh, and I do want to mention very quickly before we move on to the next M, which is modalities, and the last M is medications. Medications is intentionally at the end. I do want to mention that we will also link in the show notes the Dr. Halverson episode because that was a really good conversation about the medical trauma. He's done a lot of research on that topic, so we'll link that episode as well. And Dr. Caitlin Tuza also will link that episode. Okay, yeah. So if you have a brand new patient with EDS or HSD, POTS, MCAS, etc., what non-pharmacologic modalities are most likely to make your shortlist?
That's surely that is something that can be an issue. You kind of get a sense that you've done everything, there's nothing left. But I will say that among these modalities that I'll go through, there are different combinations of them that can be used, different timing, different situations. And really, it's almost an infinite number of possibilities of how these modalities can be applied. So I take the time to go through that with patients. It does start with kind of just easing into it though, because these patients feel exasperated that, they, like we were just talking about, years of misdiagnosis and misunderstanding. And so now I've tried this, it doesn't work. And again, from what I was alluding to earlier, it's not one miracle treatment that I've seen the most benefit from. It is a combination of all these small wins and again, maybe a combination of modalities, but just learning when to apply them correctly. So that's a roundabout way of answering your question. So I'll get to the point here. But those modalities that I go through, really, I generally start with ones that I have had experience using with patients, that patients have reported back to me, that they find benefit from, that are also the safest, though, and relatively inexpensive and attainable. So these can be things like, heat therapy for one, probably the easiest. So heating pads, warm baths, those are, and those are probably the more common ones because very often I have patients say, oh yeah, I love a warm bath. I'm doing it every day. I can't go anywhere. And, many times a patient will pull a heating pad out of a bag
Here's
or
my
purse.
heating
Like,
pad.
yeah, exactly. Yeah. So they don't go very far out of sight.
Yeah,
But
it's sitting
yeah,
right next to me.
yeah, exactly. So, it's easy, attainable, and you can travel with you. So those are great modalities. And then other things that we could talk about would be, massage and acupuncture. There's different types of each. There's acupressure, there's dry needling, there's cranial sacral therapy, there's TENS units, uh, uh, KT taping, vagal nerve stimulation. A lot of these things I know we discussed on the show, and topical medications. I know we'll get into medications, but usually it's kind of just all in one spiel. But those modalities, again, different settings, situations, and they can be a really, really effective combination.
A lot of these things I feel like can really make a difference if we set our expectations correctly. So if we expect them to take away 100% of our pain and, get us our life back, that's less likely to be achievable. But if we think about the 10% rule, which was, originally taught to me by Dr. Pradeep Chopra, our colleague, if you get 10% benefit from 5 different things, well, now you've gotten 50% improvement. So it can really make a big difference.
Yep, it's all about the small wins.
Yeah, it's all about the small wins for sure. Do you think there's particular modalities that are especially underutilized?
Okay, so I would say the most commonly used are heat, like you just demonstrated for us, and those are obviously everyone's got a warm shower, or maybe they don't have a bathtub, but they've got some source of heat. So those are probably, I wouldn't say overutilized. I would say those are very good because they're, as long as you're not burning yourself, those are very effective. But underutilized, yeah, I would say there are probably a couple that come to mind. And I would say, we talked about acupuncture, acupressure, dry needling. Uh, those I would say are underutilized, and it really depends on, like, physical therapists do the dry needling. Acupuncturists would do acupuncture. It's, based on Eastern medicine, the meridians and things. Dry needling, though, is really dependent on the physical therapist's own education, and not every physical therapist is educated on the use of dry needling. So I would say that's underutilized. TENS units too, I would say are pretty well underutilized, and those are, I mean, those are things you can do on your own. Of course, acupuncture, dry needling, you have to go somewhere, and it can, be more time consuming, et cetera. But TENS units, you can order those online. They're low risk, they're inexpensive, so I would put those on the list of being underutilized as well.
Yeah, it's amazing the difference. When I was, kind of at my worst, I'm chuckling because, my insurance covered my TENS unit, but it was this huge honking thing, and you had to get through one specific company, MP, I think it was. You had to get like all the pads and patches, and, they had like a belt for the low back and all these different things. And now you can just go on Amazon and, order a TENS unit. You can also order a clip to put on your ear to activate the vagus nerve. So there's a lot, like you said, there's a lot you can do on your own. And sometimes the TENS, by just really getting those muscles to activate, then they finally relax. Sometimes they're kind of in that constant state. And I'm glad you mentioned about the dry needling. I'll link also the episode with Dr. Mandy Blackman because we did an episode on dry needling. It's really good because it can really in the right setting, it can help, kind of turn off those muscles, but it also can actually benefit the autonomic nervous system as well. There can be some really significant changes with that. And I'm glad you mentioned acupressure because that's something that people can do on themselves, right? You can do acupressure on yourself. Yeah.
And we'll have a dry needling course coming to the University of Virginia later this fall from Jan Demerhold, who's probably the preeminent dry needling teacher in the country right now. And I would say that, yeah, it's all of those things that you mentioned. If we can get to the point that you get benefit from you're seeing someone, whether it's massage therapy or dry needling or acupuncture, but you can get to the point where you're able to do some things on your own at home, that's ideal, right? So whether it's TENS units or acupressure, that's where we want to get because those are most accessible.
Are you saying that they're coming to UVA and going to teach dry needling specifically for the UVA EDS and Hypermobility Disorder Center?
That's right. Yeah, we'll have physical therapists from the area to join in and to learn so we can have a referral base for all of those in the region that will be able to perform those services too.
That's great. Yeah, that's really great because knowing how to apply those things in this particular population is really essential. So that's wonderful that you're doing that.
Exactly.
What about braces? How do you determine when a brace is helping versus when it's becoming a crutch?
Oh, this is a good question, and it can certainly help someone function better and gradually build strength, and that's what we want the bracing to do. So if function declines whenever the brace comes off, then obviously we need to rethink the strategy. So we really have to when we are doing bracing, we can't just kind of give it away frivolously and think, "Here's your brace, there you go." We do have to follow up and assess the patient, whether it's in a clinical exam or with follow-up physical therapy visits, we do have to recognize that there is a kind of continuum of benefit that may be seen when bracing is used.
And I think the distinction between rigid bracing versus something that is more soft. I I currently have a brace on my ankle. It's actually um I want to say Apollo Neuro, but that's what you wear on your wrist for Apollo socks, compression socks, and I have a cuboid bone in my foot that's currently very unhappy and keeps coming out of place. So I'm wearing these Apollo shocks, which are really great. They're actually socks. It's not like an ankle brace, but it's very supportive. It really gives me nice compression. And it's working way better than any of my ankle braces that I had. So I think we need to also think about, is something holding the joint rigidly and therefore can potentially weaken the muscles? Or is it something that's providing compression and helping with inflammation and with proprioception and things like that? So yeah, there's a lot of tools out there that can be really helpful.
And there seems like there's more tools every day too. So I'm glad I've just learned from you about this one. So thank you, Dr. Bluestein. That's excellent. And that's what we want to have available for our patients too.
Yeah, I'll put a link in the show notes about that too, because they were designed originally for dancers because they have a little bit of padding under the toes, which a lot of dancers are dancing, barefoot. So there's a lot of, I'm putting that in quotes because they might be wearing socks or something, but they're not wearing shoes. But even ballet shoes don't have any padding under the ball of the foot. And so, we can end up with a lot of pain in that part of our foot. So the idea with these was that at least it gives you a little bit of padding there, but the compression around the ankle is really, really nice. I'm particularly wearing the ones that are a little bit looser around the toes. The first pair that I had was kind of tight around the toes, and I'm old enough that I have, some arthritis in my toes, starting to get overlapping toes and things like that. Um, so this was a really great option for me.
That's brilliant. Yeah, that makes great sense too.
Uh, is there a particular modality that you recommend quite frequently that clinicians are not really talking about?
Well, I would say, yeah. So kind of maybe in the same category of underutilized, but we and I've learned from my colleague here, Dr. Ina Stevens, who's been practicing integrative medicine for a while now, and how she educates patients on diaphragmatic breathing and breathing exercises. So that's something that's been kind of a core part of our treatment and discussions and use of different modalities. And I don't think it gets a lot of attention outside of here, and usually it takes one clinician to start, ascribing to it and finding the benefit of it for their patients, and then sharing that knowledge as Dr. Stevens did with me, and then finding the benefit also for my own patients. But unless you have those connections and those experiences, then it may be underutilized. And I think that's how it is in most other the community physicians who are treating EDS and HSD patients. And, it has profound benefit. So there's good training material on how that's done. But, when it comes to nervous system regulation, this is really a huge benefit.
I'm so glad you brought that up because that is something that's free and always accessible, right? Our breath
Always there.
it's
Yep.
always there. It's something that, you don't have to look around and say, "Oh, darn it, I don't have my," whatever, pick a modality of your choice. You don't have to say, "Oh, darn it, I have to pack that in my suitcase." That diaphragmatic breathing is something that you, at least in theory, can access at any point in time. And I agree that that's really important. I actually had a psychologist tell me once, she gave me an F minus in breathing.
Okay.
And
Yeah.
she pointed out that I was, like, breathing really shallowly, and there's data, right? Like, I remember, I actually went to the Mayo Clinic, um, 3-day pain program with a family member, a number of years ago, and they were talking about diaphragmatic breathing and data on breathing in people with, persistent pain, and isn't there a lot of data showing that, like, when we're in pain, we just breathe really shallowly, and that is not probably helping us?
No, it's just triggering our sympathetic response and our stress response, and that all, and we just like we were talking about stress making things worse. And so, and actually, we can do the opposite. We can, decrease the stress response with correct breathing maneuvers, and that's fantastic because just like we're talking about, those things that are the most accessible are really those that we want to tune into the most.
And speaking of UVA and the amazing Dr. Ina Stevens, before we go to the break, would you be able to share with us? I believe that you have some openings right now. By the time this airs, maybe you're going to have different openings at the UVA EDS and Hypermobility Disorders Center. But can you share with people how they might be able to find out what openings there are and what you might be looking for as you're building your team and really, expanding the center?
Well, that's Ben, thank you for asking first, and it is really is a consequence maybe of the good work you're doing here, Dr. Bluestein, because we're getting so many more patients who wanted to come see us, and that's great. I mean, we want to be of service to patients, but it just means that we need to continue to rise to meet this need, and our wait list continues to grow, but we just have to expand our center as well to meet that. So we've recently hired a nutritionists, a genetic counselor, some more physical therapists, occupational therapists. I think the recent openings still are with an advanced practice provider, so a nurse practitioner or physician assistant, and then an occupational therapist. Eventually, we do want to incorporate some of the healthcare professionals in some of these things that we're talking about too. So this may be a mind body therapist we've used before, licensed health and wellness coach too, that been very effective in care of our patients. So those will be available on LinkedIn to our Ehlers-Danlos Center website at UVA Health. So you just Google Ehlers-Danlos at University of Virginia. You'll see that page where those positions will be posted. So thank you for asking because that's what we want to do. We want to continue to grow, to continue to meet patients' needs.
Yeah, most definitely. Because I think a lot of people are already aware of the waiting list, and you, the listener, can help shorten the wait list by spreading the word about these openings and helping direct people to the LinkedIn page and to the links in this podcast, because we'll include a link for that as well, so people can help the community by helping build the center. So, okay,
To help
great.
everyone. Yeah,
Help everyone.
that's right.
Yes. Yes. Okay, we're going to take a quick break. And when we come back, we are going to talk about our favorite pearls about medications and supplements. So we are going to take a quick break. We'll be right back. One of the questions I get most often is, Dr. Bluestein, what products do you actually use and recommend? To make that easier, I've created an Amazon storefront with many of my favorite products for joint hypermobility, EDS, POTS, MCAS, chronic pain, etc. If you're already shopping on Amazon, I would be honored if you would consider starting through my storefront. It does not cost you anything extra, but qualifying purchases help support the mission of Bendy Bodies and allow us to continue creating free educational content for patients, caregivers, and clinicians around the world. Please visit amazon.com/shop/hypermobilitymd to learn more. Thank you so much for helping us continue this important work. We are back with Dr. Knight to discuss the last two letters of my treatment algorithm, which is an M and an S for medications and supplements. And we know that a lot of people have tried a lot of different medications, so this can be really tricky. And oftentimes people are so sensitive to medications or they've failed a lot of different treatments. So how has that reality shaped your prescribing philosophy?
Well, it's just, I would say, with anything related to EDS and hypermobility disorders, that there is certainly a learning curve, and we all started from nothing when we're going into this field, and it's been quite a steep curve. But I would say with medications as well, because a lot of the medications that I had turned to as a general internal medicine physician were very effective, and there was a broad range of conditions. We're treating everything from diabetes to hypertension to many other chronic diseases. And in some ways, we're reapplying these medications for maybe different conditions, but some similar effects that we're looking at. For example, beta blockers and POTS and things like that. Altogether, the prescribing philosophy stays the same, which is we always start low and go slow, and to really try to just only change one medication at a time, because otherwise, if we're changing multiple things at once, we don't really know what is doing what. That's a critical nature to prescribing a directive. And I'd also say that there is certainly medication sensitivity issues that come up in our EDS and HSD population more so than I would have seen in my general population in previous years as an internist. And so medication sensitivities and resistance, this does bring into the field pharmacogenomics, and sometimes there is some indications for pharmacogenomic testing when it was related to medication sensitivity or resistance, certainly if it's like class of medications. And so that all of it really just it is trying to bring better outcomes and more effective use of medications. That's really what the end result is. So starting low, going slow, only changing one medication at a time, addressing and being cognizant of the possibility of medication resistance or sensitivities to any class of medications, and then, reaching really the best results with all of those things.
So before we go on to specific medications, I have a few follow-ups on that. I totally agree with everything that you said. First question, do you have a specific guideline that you give people in terms of one change at a time? We all probably have this slightly different, and it may vary by the patient, but do you have a certain number of days, or what do you tell people when you ask them to make one change at a time? Is it 3 to 5 days, 7 to 10 days, 2 weeks? What do you?
Yeah, that's a great question. And I would say that the simplest response is that it varies by the medication mechanism itself, and we would call it half-life of the medication, right? The drug half-life is how long it takes for metabolism, at least 50% of the drug. And we use that to understand how long that drug will be in the system, and therefore what is the likely response time that we're going to see, and then therefore discontinuation response time that we would see. Now, added to that, and it's not, the science behind drug metabolism and half-life is very good. It's fairly accurate within hours, right? And I would say, though, that there's so many other things that are going on with a patient's life and all of the other, treatments and modalities that may be going on, the stress, the sleep issues, all the psychosocial things that we talked about, that I usually at least double the sort of prescribed half-life indication of stopping and starting. So if a medication has a half-life of, a day or less than a day, then I would give it, even to be on the generous side, at least a few days before we say, okay, this is or is not working. And so and actually for some of the mass cell activation treatments that we do, because there can be certainly much longer half-lives. So we're talking about antihistamines and other classes. And I may even give it up to a couple weeks before we make a determination. And before we switching around too much. Now that's also considering the urgency and the nature of the condition. So if we need to, if symptoms are so severe, we need to be more on point with the timing of it, then we may rush it a little bit. But there's so many other things that are going on in the human body and just the homeostasis of someone living with EDS and HSD that it's hard to have a hard, fast rule with a specific duration of time. I generally just, to the point of your question, I generally just err on the side of giving it more time than what we would see in specific, pharmacokinetics of the drug.
And are there certain drugs, like I'm thinking of low dose naltrexone, for example, that you might even say, let's give it a longer period of time, not necessarily before you change other variables, but before you would say, this is not working? Because I generally ask people to give low dose naltrexone about a 6-month trial. Do you do that or you handle that differently?
Yeah, I would agree with you. I think that's an appropriate response. So um, that is another good example, and there are some other mast cell activation medications like cromolyn sodium, for example, others that you end up titrating quite a bit. You go up and then you go down, you may go up again, and it can take longer. And so, uh, the half life of low dose naltrexone can, I think it'd be like less than a day. I don't know exactly off the top of my head, but the biological impact, which is what I think you're kind of describing, is longer, and it's certainly uh, you know weeks to months, and so we want to give it that kind of full course of of monitoring.
Yeah, so with LDN, even though the half-life is hours, we want to give it plenty of time so we can see what the effect is on the glial cells and also on endogenous opioids. So let's just talk just a little bit more about pharmacogenomics because I'm a lot older than you are. When I went through my training, there was no pharmacogenomics. I don't know about when you went through your training if there was pharmacogenomics, but sometimes I see what I think might be some over reliance on that data. I think it can be very helpful, but I really urge people to use it as a guideline more than an absolute because we don't really have, I don't think, enough robust data about this. Do you agree or do you think that it's super accurate?
I definitely agree because the way that I've utilized pharmacogenomic testing is directly in line with a pharmacist. And so we get, yes, we can look at the genomics to predict how someone's unique DNA will affect their response to a specific medication or class of medication. So it does kind of help narrow us down a little bit from a one size fits all approach to medicine, which we know on one hand is difficult when we have individual needs that are unique. Uh, and so it allows us to prescribe the right drug at the right dose based on someone's genetic blueprint. But yeah, at the same time, if we take it too narrowly, then we don't think about, yes, we can think about DNA and enzyme metabolism and resistance and sensitivity at that molecular level. But there are other factors involved, as we know, with regard to, DNA and genetic mechanisms of disease and therefore response to medications. So that's why I would, yes, certainly enlist the help of a pharmacist when we're thinking about these things. And then also thinking about the indication of the medication to begin with. So this class is not looking like it's going to work, but there are no other classes, then maybe we sort of just do have to do some dose adjustments and things like that and not say that, okay, your pharmacogenomics is specific DNA, unique DNA characteristic is, you're going to have a nil response, but there's no other classification, then let's kind of keep working with this category of medications. So we have to take all of those things in consideration. I agree. It's just another tool among many tools that we have at our disposal that we just put it all together.
Yeah, and that's what I tell people about fluoroquinolones. It's not that we don't ever, ever, ever take them, because if you have allergies to different antibiotics and, you're limited and you have an infection and it's sensitive to fluoroquinolones, but not a lot of other things, you always have to take into consideration the entire clinical picture. What about deprescribing? So I don't know about you, but I see a lot of people who are on a lot of medications and a lot of supplements. And sometimes I look at their medication list and I think, oh my gosh, maybe the fact that you're on like 3 different or 4 different antidepressants at this dose is actually making your symptoms worse, not better. And so I wish that we were taught more about deprescribing in medical school, but we're not. So, is that something that you find yourself doing with this patient population?
Well, definitely. And there is certainly a lot of trial and error that goes on when we're talking about all of these modalities and medications and everything that we're discussing now. And where the trial comes in is that there may definitely be medication that we have to move away from. It's either ineffective or the side effects are too severe, and this happens all the time. And so that's why we start low and go slow so that we can monitor for any adverse response and that we can make quicker adjustments before they become so profound that causes someone's blood pressure to bottom out and they end up in the hospital or vice versa. It's something else untoward can happen. So deprescribing is just as important as prescribing. And we do, again, have to think about, half-life and duration of biological effects when we're deprescribing, because that may uh, be considered when we're starting a new medication. How long is this other medication actually out of the system before we add something, similar or right on top of it that also may make some side effects worse. So, for example, some antidepressants, it's a range of weeks, if not longer. And we have to taper off some medications, so we may go down on the dosage. Again, depending on the half life and the situation, but all of those things are critical in the nature of deep prescribing medications.
And I'm glad you mentioned about the taper, because that is so important. And with a lot of those antidepressants, yes, even if you taper slowly, it can be pretty rough. So, what medications have most changed your practice?
Wow. Well, I would say those that have really been novel. I would say one, so they're kind of novel class of medications. You mentioned low dose naltrexone. This has been around for a while, but the targeted use of it and benefit of it, this is something that has gotten a lot of attention recently, and for good reasons. It has been very helpful for many patients and has very good safety profile. I would say that also a newer one too that has been getting attention related to pause is Aberdeen, and I've seen a lot of benefit for patients with that. Some of the newer migraine targeted therapies too. There's been a real upswing in a variety of migraine headache medications and therapies that patients would say they describe them as life changing. And then, mast cell activation related, those that have been around for a while have been tried and true. The antihistamines, second generation, if they are able to see some benefit from it, like the non-sedating Zyrtec or cetirizine, Allegra, and so forth, Claritin. So those are, really good ones. Beta blockers for POD symptoms as well. Again, there's any number of patients out there have not had the benefit that we would like to see. But I would say those are probably at the top of my mind as far as medications go, because when we get into discussion about EDS and hypermobility disorders, we know that medication is very difficult because the chronic nature of the pain. This is why many of the pain medications, the Tylenol, Advil, are not really our best friends. I mean, can be in certain situations necessary and useful, but the ongoing problematic effects of hypermobility can mean that the medications are difficult to find that one that really makes the difference.
And we know that there are no on label treatments for hypermobile EDS and HSD. So, all of the treatments that we use are quote, off label. And I've discussed what that means in another podcast and without taking too much time. It just means that we're like repurposing the medication for a different indication than what it was originally approved for. But that's what we do. We do that all the time. So that's not, it's just something to be aware of, but it doesn't mean that it's a bad thing. And when it comes to things like POTS, postural orthostatic tachycardia syndrome, do you have favorite medications for that? For example, do you use protostigmine, midodrine? You mentioned Avabradine, which does help with the heart rate. What about those or fludrocortisone? Are those things that you prescribe very often?
They are, some more than others, and it's interesting, and you talk to different clinicians too, they've kind of got their go-to as well, and that, may range from, I have a colleague in Atlanta, Howard Snapper, who really favors, desmopressin. Uh, Dr. Alan Posinki really favors the propranolol, the beta blockers. And then, yes, I have patients come to me who have already been on the midodrine, and that's helpful in the cases where they've really had a lot of hypotension and issues with low blood pressure. And so it ranges. There's different situations and different settings. Yeah, I mentioned the Avabradine and yeah, the Florinef. It can be also in the right setting. It can be useful. I would say that probably the ones that I turn to the most often would be the beta blockers, though, at least to get things started. And I'm learning a lot from Dr. Snapper about application of things like desmopressin, and then, of course, the midodrine and Florinef too. And you mentioned pyridostigmine too. So there's certainly a potential benefit of that.
I heard on a long COVID webinar once, I heard them talking about treatment roulette. And I think it's important to point out that as much as Dr. Knight knows and as much as I know about this patient population and these conditions, unfortunately, we don't really have great indicators yet for what medication is going to be most successful for a given patient. So it does require trial and error, which is frustrating for everyone involved. Do you see certain prescribing mistakes more commonly that you want people to be aware of? Because we know there's a lot of clinicians that listen to this podcast. So are there things that you want people to be aware of in that regard?
Well, we touched on it earlier, and this is a great question because I see one of the most common problems is related to polypharmacy. So when we're talking about deprescribing and the importance of deprescribing, it's to avoid polypharmacy, and it's to avoid just racking on more and more medications because more and more problems, and trying to find a solution with a drug, and we end up chasing our tail, or at worst, shooting ourselves in the foot. So we're adding medications to treat side effects of other medications at a point. I understand the extreme version of it, and I've also seen this happen too, as patients would say, "All right, I'm just stopping everything," and they just stop everything abruptly. Like, well, we don't want to do that, but let's kind of find the intelligent way through this to remove those medications which may either be causing side effects and what those side effects are, and then as far as any other medications that are being used to treat those side effects. So yeah, that's kind of the gist of it. But I would say polypharmacy is something that's really it is all too common in our patients because there's so many conditions and symptoms and variety of symptoms that our patients suffer from everything from migraines to stomach issues to pain issues. And it's not to say that these medications are not necessary. I mean, there's certainly are cases that, someone can, yes, have. We talked about victims, dictums, right? Everyone can have as many problems as they want. And, those problems may need treatment, but we have to also think about how these medications may interact with each other.
Let's move on to supplements because we're going to be running out of time soon. And I feel like we could have taken this entire time to talk about medications and supplements. Maybe we'll do that at future time. Lots of patients, as I'm sure you've seen, spend many, many thousands of dollars on supplements. How do you think supplements fit into an evidence-informed treatment plan?
I will say first, they fit into a capitalist market, that's for sure, to begin with, because there's lots of people who want to make money off of selling you supplements. And so, buyer beware, I would say to begin with. Obviously, consult with a physician. I would say very often physicians are not consulted about supplement use and intake. I'm very grateful when patients do bring it up, but most often I have patients who have already kind of just started and this is what I'm taking. I'm like, all right, well, anyway, let's spend some time going through them because they are important. And I agree this could certainly warrant a full episode. But supplements, all in all, I mean, they can be fine and they can certainly be a solution, but they should solve a problem, not just create a collection of supplements and then just creating extra financial burden for someone because they do add up very quickly. So if it's like a nutritional or vitamin deficiency, I work on correcting those deficiencies using the simplest regimen possible, rather than these kind of multivitamins and things like that, which certainly get more expensive. So we target what are the specific deficiencies, and we kind of work through it from there. And then any number of different reasons why a supplement might be used. We can talk about the condition, the symptoms, and see what may be the most effective therapy.
I had a patient the other day who is on a carnivore diet and was diagnosed by her PCP actually with scurvy. Her vitamin C level was that low, which of course is going to hurt your connective tissue. So you're absolutely right. While we have to be careful about overprescribing supplements and overutilizing supplements, there are true deficiencies. And we had a great conversation, you and I, with Dr. Gregory Plotnikoff, which I also want people to check out about vitamin D. So yeah. So at the same time, we need to be very cognizant of what things need to be corrected and what's the best way to correct them. And are there ways to evaluate and see, is this something that's needed? And unfortunately, for some things like magnesium, we don't have good tests, but for vitamin D, we do. So sometimes we have good tests for things and other times we don't. So, um, and there's other supplements that they have no test at all, but we can, if it's safe, we can consider doing a trial. For example, palmitola ethanolamide, abbreviated as PEA, can be very helpful for pain, inflammation, central sensitization, stabilizing mast cells, and things like that. But we need to be very thoughtful about what we're using and be very aware, like you said, about the capitalists. There's almost no limit to the number of options, especially if you start looking at peptides, and then you look at the labs that are being direct to consumer type labs that are being marketed to people. So a lot of this, I think, is overhyped. So are there certain supplements in particular that you think are overhyped?
Oh wow, that's a good question. Well, um, yes, and I would say those that give the impression that they're going to cure everything, right? And that may be that may be true if it's something that helps sleep, and sleep improves this and that, and right, well, maybe it does cure everything, but to label it as such and to kind of market it in that way, then I would be wary of what's actually in that, because they might just throw in a whole bunch of different things that this does X, Y, and Z, this does whatever else, and those at excessive levels, those other added ingredients may not be very good for you. So I think anything that is marketed in that fashion is something that could be concerning. Otherwise, you mentioned magnesium and vitamin D. Yes, of course. Iron is also another one that we pick up on patients with low iron levels that is needed to be supplement. But and then, the omega-3 fatty acids and so forth. But, I would just be wary of those that kind of have this far-reaching claims.
Right. If anytime somebody uses the word cure, almost in association with any condition, that should raise a yellow flag at the very least, and possibly a red flag, because in medicine we don't have cures for for very many things,
Exactly,
much less in this
exactly.
space. Yeah.
Right, right. Much less something that's just not FDA approved, right? It's just on the supplement market.
Yep. Yep. So let's move on from that. And in the last 2 minutes, let's talk about lessons that you've learned that you want to share with clinicians. You've spent years building the country's best connective tissue disorder programs. Looking back, what do you do differently now than you did 5 or 10 years ago?
Wow, and it's you know, it's easy to look back on our mistakes, but it's also it's it's striking to me how fast these things go by. I mean, because we're constantly, I mean, whether it's, we're hosting podcasts or doing research or hiring or training and educating others, it just the time goes by so fast. But there are certainly things that we've learned along the way, and I have personally learned that taking for example this episode, like talking about medications and supplements and modalities and psychosocial things, that it's uh, really, it's a waste of time looking for one single answer. Like, what is the one single? And this gets batted around between POTS and mast cell and hypermobility, and we're talking about the biological mechanisms and single gene mutations and final common pathways. I mean, there's a lot of time and there's a lot of, value in that research and those discussions. There's also a lot of time wasted where we could really be focusing the energy on here and now. How many patients are out there who need help that otherwise don't have any help? That let's focus on attending to those. And then we're kind of building the research models and doing the experiments to move the science forward in the interim. But let's get patients cared for. Let's get this information to other providers as well so they can care for patients better. So it's really building this full comprehensive framework and across this health system, across the country, really, for patients to be attended to better.
And what do you think separates clinicians who become excellent at caring for these patients from those who struggle?
Well, I think we use the cliche of thinking outside the box a lot, but I really ascribe to that because these disorders that we know affect far more than just joints. They influence every organ system, every aspect of someone's life too. I mean, not just the tissue itself, but their psychosocial effects that we were talking about earlier, their work-life balance, their relationships, and so and it may not really just be the kind of out of the box thinking in the traditional sense, but at least just that kind of the generalist view on, integrative medicine approaches and all of those things that we kind of tie into it, functional medicine approaches, all of this other modalities that we're thinking about. We have to look broadly about, what these conditions affect, and therefore also what we can use to treat these conditions. And I would say those are what separate the good clinicians from the rest because they are thinking broadly.
If listeners remember just one thing from today's discussion, what do you want that to be?
Oh, wow. Well, we've certainly gone through a lot, and I hope it hasn't been too confusing because sometimes it gets very confusing to me very quickly too when we talk about all these things that we could try. And I'm also learning so much as well as I go through this. So I've learned a lot from you, even just from this episode, Dr. Bluestein. So thank you. And I know our listeners are learning a lot. So I would say, if there is one thing to take away, that really the whole process of this treatment and recovery is, as I alluded to this earlier, it's not just one specific miracle treatment, one missing piece, and I think that's what a lot of people are looking for. They're looking for this one specific thing, and I sound like I'm repeating myself, talking about lots of small wins, but really it's about understanding all of those small wins along the way and the whole person, understanding the whole person and all of those meaningful gains that can be of benefit to that person. So when we do that consistently, patients improve far more than anyone thought possible. So if we're looking for all of those areas of improvement rather than one specific thing, then it's really tremendous how much improvement I can see in someone's trajectory.
I think oftentimes it's easy to realize when you're getting worse, but it's not easy to recognize when you're getting better or when things are improved. I was texting with a friend of mine the other day who was there for me when I was at my worst. And we're texting back and forth. It was my birthday. So he had like texted me and wished me a happy birthday. And somewhere along the way, he wrote, "Wait, you're not in pain every day anymore?" And I wrote back, actually, now that you mention it, no. But I hadn't talked to him for a while, so in his mind, he was like, "That's amazing." And I knew that it was amazing on some level, but I also this conversation with him, like, really made me realize how incredible that is because it's just we adapt, right? We adapt to whatever's going on, whether it's worse or it's better. We adapt, and it's very easy to focus on what we would still like to be better.
And so, I think you hit it right on the head is that we may not just focus on symptoms alone. We just may focus on function and quality of life and joy of living and what are patients engaged in? Are they engaging with their friends and family in the way they want to? Are they able to participate in their hobbies that they've previously enjoyed? So I think that's the core of it, that we want patients to be able to do the things that they want to do.
Absolutely. I think focusing on function is so important. I remember when I was having a lot of problems with my wrist, and the pain most of the time wasn't bad. Like if you asked me a pain number, it'd be like, oh, 1 or 2, but I couldn't open a door. So, focusing on function, I think, is really essential. Um, do you have a hypermobility hack to share with us to wrap up this episode by any chance?
Well, I I don't really have anything right offhand, but I guess when I'm putting all of these things together is that yeah, I mean, maybe just like you said, that improvement is a form of treatment and maybe a form of a cure itself, even if we're not looking for a cure specifically. So improvement, small gains, small wins, every small win is a hack in itself that we just continue to build on.
Love that. I'm writing that down. Okay, and I have a very, like, just practical quick hack to add, and that is there's a lot of specialty labs out there. There's a lot of companies that are marketing directly to this population. Unfortunately, there's kind of like this gold rush mentality. I think a lot of people have figured out that there's a lot of people walking around with possible hypermobility disorders or symptomatic joint hypermobility. And so companies are catching on. So, number one, be aware of that and be cautiously optimistic, skeptical, like, put on your detective lens and see, like, is this really necessary? Is there really data and science behind this? And also, some of these labs are ones that you can get through Quest or LabCorp or, some of the more major, Mayo Clinic. So don't assume that if a lab is being marketed to you, that it's something that you have to do through that company. And also for patients that are listening right now, you can make life easier for your clinicians if you look up, like, okay, here's the CPT code, here's a diagnosis code that makes it more likely to get this lab covered by my insurance. For example, let's say you want to get like the omega 3, omega 6 index. That is something that you can get through one of these labs, but there might be certain diagnosis codes that your insurance requires. So if you do that homework for your clinician, that can be really helpful. So that's my little hack on top of your hack, which I love. Um, okay, before we go, can you just share with us any special projects that you're up to or anything that you're especially excited about and where people can find you?
Well, certainly our program growth is very exciting, and it's just like I said earlier that we're rising to meet the needs of those patients in this growing wait list, and that's what I really hope to uh, uh, be able to attend to for patients across the country. So I guess one other very exciting thing is that I've been mentoring a colleague at University of California, San Francisco, to build on a budding EDS clinic there, and really to be helpful to patients on the west coast of the country. And so before everyone goes out and inundates her with a massive wait list too, uh, give her some time to continue building that, and I will continue with my help and building that with her. And there have been 2 MDs who have replaced me at the Mayo Clinic EDS clinic. So that's I'm always excited to see that these programs expand whenever wherever possible across the country. So I'm on LinkedIn. I'm on not many social media places actually because I kind of leave the social media to you, Dr. Bluestein. But I am here on Bendy Body's podcast as well.
Yes, and we are thrilled that you are. It's a wonderful way for people to learn from you and learn what incredible work that you're doing at UVA. And I love that you're doing this empowered relief and the teaching with the dry needling, just to circle back to those things. I mean, you're just doing some incredible things there. So that's really fantastic. So I love that you're mentoring somebody who is looking to start another EDS center. I do that as well. I offer professional mentorship, and I'm actually mentoring a couple of physicians in other countries, which is really exciting. So I think there's so many reasons for people to be hopeful right now. And that's also a huge goal of this podcast, is to just let people know, like, we are there for you. We are really trying to help you. And Dr. Knight is such an essential member of this community and leader in this space. So this was such a fantastic conversation. Thank you so much for joining me again, Dr. Knight. And I just love all the great things that you're doing. I don't know how you do it all. You're in a lot of different places doing a lot of different things, but keep it up, please.
Thank you. Thank you so much, Dr. Bluestein. It's always a pleasure to be here.
I'm super excited to tell you about the Bendy Bodies Boutique. I am so proud of our fierce styles and flexible designs. These are created by hypermobile artists for hypermobile shoppers. There are so many fun items, from clothing, accessories, home goods, and my favorite are the bags. I especially love the Weekender tote with one of the EDS Tough designs. Whether you're shopping for yourself or someone you love, there's so many options to choose from. A portion of the proceeds goes to support EDS nonprofit organizations. For more information, please visit bendybodiesboutique.com. Thank you for listening to this week's episode of the Bendy Bodies podcast. If you'd like to go deeper, I share additional education, clinical insights, and resources in my newsletter, The Bendy Bulletin, which you can find on Substack at hypermobilitymd.substack.com. You can also help us spread the word about connective tissue disorders by leaving a review, sharing this episode, or sending it to someone who needs it. These small actions truly make a difference in raising awareness about these conditions that are still widely misunderstood. And don't forget, full video episodes are available every week on YouTube at Bendy Bodies Podcast. As many of you know, my passion is helping people better understand and navigate symptomatic joint hypermobility. In addition to my clinical and educational work, I offer one-on-one coaching, professional mentorship for healthcare professionals, and expert witness services. If you'd like to learn more, please visit the services page at hypermobilitymd.com. You can find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, X, and LinkedIn, all at HypermobilityMD. As part of our collaboration with the UVA Health EDS and Hypermobility Disorders Center, we also want to share a few helpful resources. For questions or appointment inquiries, you can contact them at ruvaedscenter@uvahealth.org. That's the letter R, uvaedscenter@uvahealth.org, or call 434-243-8200. Our incredible production team is Human Content. You can find them on TikTok and Instagram at Human Content Pods. We love bringing on guests with unique perspectives to share. However, these unscripted discussions do not necessarily reflect my views or opinions. Furthermore, perspectives expressed within Bendy Bodies Media, including this podcast, do not reflect the views or opinions held by Human Content, Inc. Although we may share healthcare perspectives on this podcast, no statements made on Bendy Bodies should be considered medical advice. Listening to or watching this podcast does not constitute a doctor-patient relationship. Please always consult a qualified healthcare provider regarding your own care. For information about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, HIPAA release terms, or to get in touch with us, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.